Assalamu alaikum warahmatullahi wabarakatuh. Dear students, it's my pleasure to be with you today. I'm Dr. Ashraf Balba. I'm a professor of surgery, Faculty of Medicine, Montefiore University, and I'm the coordinator of the current module, which is endocrinology and breast. I will be glad to have your comments and your questions through the written email. By the end of this lecture, we are expecting you to be able to define the anatomical boundaries of the neck, to outline what are the different swellings of the neck either in the midline or in its lateral side, and how to differentiate between these different swellings. These are the references that have been used for preparation of this lecture, mainly Bell and Love, Sebastian Textbook of Surgery, and Browse, Signs and Symptoms for Surgical Diseases. I'm also reminding you that the lecture will have a lot of photos, will have very little knowledge to be written within the slides, so I remind you to bring your notes, write down what you feel it is important, and try to pay attention of what I will say. Before we go into the details of these swellings one by one, we should know first, as we are talking about the neck, what are the boundaries, what are the anatomical boundaries about the neck. We have two important muscles in the neck, which is the sternomastoid muscle and the trapezius muscle. These muscles are dividing the neck into two triangles. The part which is anterior to the anterior border of the sternomastoid is called the anterior triangle of the neck, and the part which is posterior to the posterior border of the sternomastoid is called the posterior triangle of the neck. So the boundaries of the anterior triangle is the anterior border of the sternomastoid, the midline, and the lower edge of the mandible. While the posterior triangle is bounded by the posterior border of the sternomastoid, by the anterior border of the trapezius muscle, and the clavicle. So we have two triangles now. What about the structures that will lie just underneath the muscle? If I have a structure which is under the sternomastoid muscle, it will be considered as if it is a part of the anterior triangle of the neck. Going into more details about the triangles of the neck, we have two muscles in the neck. Each of them has two bellies and central tendon. The digastric muscle, which has anterior belly, posterior belly, and central tendon. The omohyoid muscle, which has superior belly, inferior belly, and intermediate tendon as well. These muscles are further dividing the triangles of the neck into smaller triangles. Between the two bellies of the digastric, anterior belly, posterior belly, and the inferior border of the mandible, there is a triangle here. It's called submandibular triangle or digastric triangle. And between the posterior belly of digastric, the superior belly of omohyoid, and the anterior border of the sternomastoid, there is a triangle here. It's called carotid triangle. Anterior to these triangles, I have here triangles called muscular triangle. And between the anterior belly of the right digastric and anterior belly of the left digastric, I have here something called submental triangle. While the posterior triangle is divided by the inferior belly of omohyoid into upper bigger triangle, it's called occipital triangle, and smaller lower triangle is called suprascapular triangle. Why we are dividing this? Because definitely with each part, with each triangle, there are some of the anatomical structures that are commonly present in this triangle. So if I will have example here to the digastric, to the submandibular triangle, I have here the lower part of the parotid gland. It may emerge here. I have here the submandibular salivary gland. I have here the submandibular lymph nodes. So whenever I will find something within this triangle, mostly my mind will be directed to these structures. Here is related to the carotid artery. So if I have aneurysm of the carotid artery, if I have carotid body tumors, mostly it will be within this triangle and so on. If I will now enumerate or enlist what are the differential diagnoses of swelling that are present in the lateral side of the neck, I will follow the same division that we have already followed in the previous slide. So if I will start from up down, I may have parotid swelling, that will be mostly in this part. Submandibular gland swelling, that will be mostly in this triangle. Also in this triangle, but more anterior, maybe in the submental triangle, I may have something called ranula. If we go here to the upper part of the neck, between the upper third and lower two-thirds of the sternomastoid, in this part in particular, I may have what's called branchial cyst. Laryngocele can also present in this part. Within the carotid triangle, I may have carotid body tumor and carotid artery aneurysm. Within the lower part of the sternomastoid, I may have a swelling called the sternomastoid tumor. All through the jugular vein and also through the superficial distribution of the lymph nodes that you have already had the last year, I may have lymphadenopathy. If I will go down anteriorly, I may have thyroid lobe enlargement. In the root of the neck, in the posterior triangle, I may have cystic hygroma and cervical rib. We will pass through every one of these diagnoses to know what are the main presentation of the patient, what are the signs that I may elicit to differentiate one swelling from another. The first swelling that we are talking about is the parotid swelling, and we should know that most of the pathology that occur within the parotid gland will present as swelling, either inflammatory obstruction, tumors, either benign or malignant, all will cause either generalized enlargement of the whole parotid or localized enlargement within one of its portions. So I will find a swelling that is present in front of the lobule of the ear, and sometimes it will go down between the furrow of the mandible and the mastoid process by enlargement of this part. So what are the manifestations of this swelling? The main manifestation, I will have swelling within this region, and characteristically, the swelling, if it is large enough, it will raise the lobule of the ear with the sign that you have already seen. Also, as long as, based on the anatomical knowledge, that this swelling is more superior, more superficial to the masseter muscle, whenever I will ask the patient to contract the masseter muscle or clenching the teeth, the swelling will be more prominent because the swelling is more superficial to the muscle. These are the two main pathognomonic features of parotid swelling. Definitely, if I will diagnose anatomically that this is parotid swelling, I should go further for differentiation of the pathological diagnosis, whether this is inflammation, whether this is tumor. You will go into the details in the next module, inshallah. The second gland is the submandibular salivary gland, and anatomically also, as you see, the submandibular gland is in the furrow just under the mandible, the lower edge of the mandible. So some parts of the submandibular gland is underneath the lower edge of the mandible. If I will translate this clinically, I will find a swelling again that is present in the submandibular triangle, as we know now the anatomical relation. And one of the pathognomonic features that this swelling, as long as it is attached underneath the mandible, cannot be rolled against the edge of the mandible. If I have submandibular lymph node, which is present here in this part, the lymph node doesn't have this attachment, and if I will draw it across the edge of the mandible, it can go up. And I think most of us, if have tried this whenever you have some of the sore throat or whatever, and have some of the lymph nodes that are present in this part. Some of you may play by giving this lymph node across the edge of the mandible. But with the submandibular salivary gland, due its anatomical relation, it never can go across the edge of the mandible manually. The other pathognomonic feature that this, or the deep part of the submandibular gland, is just underneath the mucosa of the mandible. So it will be very easily to be bidigitally filled. If I will just push from outside with one finger, putting the other finger in the floor of the mouth, under the tongue, just on the mucosa of the floor of the mouth, I can feel the swelling very easy. While if I will have other swellings like lymph nodes, it cannot be felt from inside like this. These also the two pathognomonic features of the submandibular salivary gland enlargement. The next swelling is something called ranula. And what is this ranula? What is the meaning of ranula? It is something or one of the swellings that are related to the third large salivary gland. We have already talked about the parotid, the submandibular. Now it is something related to the sublingual gland. And as you see here, that the parotid and the submandibular gland, each one of them has one duct. However, the sublingual gland has several ducts that will open directly into the floor of the mouth. So what is ranula? It is a mucus cyst which is present in the floor of the mouth, and this cyst is mainly related to rupture of some of these ducts after its obstruction. If one of these ducts has been obstructed, the secretions that should be poured into the mouth will be retained. If they are ruptured, they will form a mucus-filled swelling that will be presenting in the floor of the mouth, and this is called ranula. So we have known now what is the pathological name of ranula, but what is the linguistic name, or why it has been named like this. Really, ranula in Latin is called is meaning the frog belly, or the stomach of the frog, because it has been named like this because the ranula will present with a swelling, as you see, that maybe that much resembling the belly of the frog in its shape and in its color. It will be bluish in color, it will be grayish in color. So this is why it has been named this way. So this is ranula, and definitely, as we said, it will be presenting mainly inside the mouth. So why we are including this within the neck swellings, we will see just right now. What is the history that I will take in this case? Mostly it will affect the children, young adults. There's no gender preference for this. Both genders are affected equally. And the main complaint will be swelling in the floor of the mouth. That will gradually grow up throughout several weeks, and rarely it will be great enough to interfere with eating or to interfere with the speech. How it will present, if we will examine it by the same way that we are used for the examination of the swelling that we have already studied the last year. You will find the site of it will be in the floor of the mouth, just between the tongue and the alveolar margin. Its color is characteristic. It may be bluish, it may be grayish in color, and it's more or less globular in shape or rounded in shape. It has different sizes, but it doesn't attain very big sizes, maybe up to 5 centimeters. And characteristically, its surface is smooth, and the edges are well defined, and it is soft in consistency. One of the pathognomonic features of it that it has clear fluid inside, so it has positive transillumination, and it is what's called translucent. As if you go back to the examination swelling, definitely you will remember what is meant by positive transillumination. So all of this, we are talking about swelling that is present within the floor of the mouth. But why we are including it in the neck? If this has attained large sizes, sometimes it will dissect within the floor of the mouth or the mylohyoid and present in the neck like that. Will present with neck swelling. How we will diagnose? By its anatomical position, and if we ask the patient to open the mouth, we will find the characteristic features of frenula as you see. The neck swelling is called branchial cyst, and from its name, it is something related to the branchial arches or the pharyngeal arches if you go back to the embryology. What are these? We have 5 pairs of branchial arches. One of them will be rudimentary, and the main prominent will be 4 in the 4th week of gestation. And from the inside of this branchial arches, we have the endoderm, and from the outer side we have the ectoderm. Each one of these branchial arches will be responsible for development of part of the head and neck with its nerve supply, with its blood supply, and the cartilage or the bones that will develop from this part. From inside I have something called pouch, and from the outside I have something called cleft. What will happen? This is only one side of these pharyngeal arches or branchial arches, that at the 7th week of gestation, I will have a process that will develop from the second branchial arch, from the ectodermal side, as we know here. And this will go caudally till it will fuse with the 4th branchial arch. So this part or this process is called operculum, and once it will fuse, I will have something here inside, definitely as you see here with the color, it is lined with ectoderm, and the main or the normal fate of this, that it will obliterate and it will disappear. So what if this part will not disappear? A cyst here will develop, and this cyst, as we described earlier, is mainly made with ectoderm. It will be still connected to the side wall of the pharynx, mainly the second pouch. Here is the palatine tonsil, so there will be connecting duct to the side of the floor. Whenever this will enlarge later on in life, a cyst will appear here. Just I want to pay your attention for something, that I have some of the structures that will be developed from the second arch, like the external carotid artery, for example, and I have some of the structures that will develop from the 3rd arch, like the internal carotid artery. So whenever I will have this track later on, I will find this track will pass between the external carotid artery that is driven from the second arch and the internal carotid artery that is driven from the second arch. So this is what's called the branchial cyst. Sometimes the cysts will not completely be closed like this, but there still will be connection to the skin, and a fistula or sinus will develop. It's called branchial fistula. How the patient will present, what are the symptoms that are present to these patients, in spite of the swelling or the embryology of the swelling or the etiology of the swelling occurring in the intrauteral life, still the swelling cannot present except later in life, in the adult life. So I will not find the newborn to be affected with that. In the adolescence or in the late teens ages, the swelling will start to appear. Both genders are affected equally, and the main presentation of the patients will be swelling in the lateral side of the neck, and this swelling is painless, except if the swelling will be infected, and this swelling will be infected by infection of some of the lymphoid tissue within the cyst wall. At this moment, the swelling can be painful. What are the signs that can I elicit or find whenever I will examine a patient like this? The patient will present with the swelling in the upper part of the neck, mainly in the junction between the upper third and lower two-thirds of the sternomastoid. I will find the swelling underneath or deep to the sternomastoid, and this is really explained by what we have said, that the second branchial arch, which is making the operculum or making the process, is responsible for the development of the sternomastoid. So I will find the swelling is underneath the structures that are going to develop from the second branchial arch, so the sternomastoid will be above the swelling. Only the anterior part of the swelling will project from the anterior border of the sternomastoid. This is as regards the position or the site of the swelling. What about the shape? There will be globular in shape. The size will reach maybe up to 5 centimeters to 10 centimeters. It is oblong in shape, and it has smooth surface. Consistency, it will be cystic in most of the cases. So I can elicit fluctuation in it, except it is very tense in some of the cases in which the swelling will be tense, cystic, and fluctuation may be difficult to be elicited. What else? If I will go into the content of this swelling, it will be desquamation from the ectoderm that is present, because we said that this is lined by ectoderm as you go back to the embryology. So I will find that this swelling is radio-opaque because the content inside are not clear. Whether I will find it tender or not, according to the situation. In most of the cases, it is not tender, except there will be infected swelling. At this moment, it will be tender, and I may find some of the lymph nodes in cases of infection. How I will treat this swelling? Definitely the main treatment will be surgery by excision. If we just open in the neck and we make the section under the sternomastoid, I will find the swelling. And don't forget that this swelling will be attached by a tract to the lateral wall of the pharynx, as we already described. Another example of branchial cyst with its exact classic position in the neck, it will be excised like this, and this is the sternomastoid that has been tracted, and this is the tract that will be attached to the lateral side of the pharynx, as you see, like this, to be excised in a hole. However, if we go to the same embryology again, we said that there will be a cyst that is attached to the lateral wall of the pharynx. However, if this operculum will not fuse completely with the fourth branchial arch, there will be connection to the skin, and something will be called branchial fistula. And the patient will present with swelling or just opening in the anterior border of the sternomastoid that may be unilateral or maybe bilateral. And if we go with the track upwards, we will find it attached to the lateral wall of the pharynx. Characteristically, this track will pass between the external carotid artery and the internal carotid artery. Why this again? Because the external carotid artery is formed by the second branchial arch, so it will be the external carotid artery will be superficial to the track. However, the internal carotid artery is formed by the third branchial arch, so it will be deep to the tract. Definitely, treatment is by excision of the tract, but be careful whenever you go between the internal and external carotid arteries. The next swelling is carotid body tumor, and from its name, it is something related to the chemoreceptors that are present between the internal and external carotid artery. You know, at the bifurcation of the carotid artery into internal and external, there are some of the chemoreceptors that are present there, and tumors that will grow from these chemoreceptors is called chemodictoma. Usually they are benign, but sometimes they are malignant, and if they will enlarge, they will present with a swelling in the lateral side of the neck. How the patient will present? The most common age is between 40 and 60 years old, and the main presentation of the patient will be swelling that is painless and slowly growing within the neck. Where it will be present in the lateral side of the neck, definitely in the carotid triangle as we have already described. And sometimes the patient may notice that this lump pulsate, but this is definitely will be an important sign whenever we go to the examination. One of the manifestations that you may ask about, or the symptoms that you may ask about, that the patient may feel some of the transit cerebral ischemia or ischemic attacks, like some of the blowouts or transit paralysis or the paresthesia. The growing of the tumor is slowly, and sometimes it will be bilateral. If we go to the examination of the swelling, what will be the examination? We will follow the same sequence of examination of swelling that we have. First, the site, it will be in the upper part of the lateral side of the neck, mainly at the level of the hyoid bone, mainly in the carotid triangle that we have already described earlier. What about its shape? It will be globular in shape, sometimes as long as it is between the external and internal carotid artery. The lower part will be a little bit tapered downwards, and it will give impression of something oblong like that. Sometimes it's called potato tumor. This is about the shape. It is not tender. The consistency is solid. Sometimes it is hard. One of the pathognomonic features that are present here is the swelling appear as if it is pulsating. Go back to the types of pulsations that you know. We have two types of pulsation, either transmitted or true. Mostly it will be transmitted pulsations by the swelling, this transmission from the swelling of the carotid artery. So if I will put two fingers here, I will find the two fingers will be just raised without separation. One of the precautions that we should tell whenever you examine this part, that it should be examined gently whenever you palpate it, because if you have vigorous manipulation of this tumor, sometimes the patient may have some of the vasovagal attacks. This is just to show you how this will be present between the external and the internal carotid arteries, and the lower part of the tumor may be tapered downwards because it is present in the angle here, and definitely the treatment will be excision without definitely compromising the internal, at least the internal carotid artery, because it will go to the brain. This is the chemodictoma that will be present between the internal and external carotid. You can imagine how the pulsation can be transmitted by the carotid artery whenever you palpate it, and it is not actual pulsations. One other swelling is laryngocele, and from its name, it is definitely a swelling that is related to the larynx by outpouching or dilatation in part of the laryngeal saccule that extends within the false vocal cords. So I will have this swelling to be just internal or external, but as long as the external definitely will be connected to the internal part, so it has been divided into either internal laryngocele or combined internal and external laryngocele. Why these laryngocele or outpouching develop or diverticulum develop? Sometimes it is attributed to some other congenital factors. Most of the theories are saying that it is related to increased laryngeal pressure. Where I will find this in musicians that will have the wind instruments, wind instrument players, and the glass blowers, because the one who are making some of the glass manufacturers, they blow within the glass to make it enlarge. Or if I have mechanical obstruction by pathology like carcinoma or other factor, so this obstruction may induce that the outpouch will occur. This is the main two jobs that maybe encounter this, either glass blowers as we see here, or musicians with that will exert some of the pressure while they are playing their instruments. If you will go to the presentation, we will find the patient will present with a swelling in the lateral side of the neck. Sometimes it is in the midline as well. Present in the upper part related to the sternomastoid. It has smooth borders, globular in shape, but one of the pathognomonic features that this swelling is compressible and it will increase in size with Valsalva maneuver whenever the patient will exert expiration against obstruction or against obstructed glottis. It will increase in size as long as it is related to the larynx. Another swelling that we will discuss is the pharyngeal diverticulum, and from its name it is diverticulum or outpouching, but at this moment is coming out from the pharynx and not the larynx like the previous swelling. From where it will come out, I have here a defect, like the same theory of hernia, that weak area within the pharynx between the transverse fibers of cricopharyngeal muscle, which is the upper esophageal sphincter, and oblique fibers of the inferior constrictor of the pharynx. This will form a triangle. It's called Killian triangle, and it is only covered with mucosa. If I will have overactivity of the cricopharyngeal muscle, and there will be swallowing against contracted muscle, there will be increased pressure within the pharynx with a weak area in the wall, so there will be outpouching and the pharyngeal diverticulum will develop. How the patient will present: the main presentation will be in the middle and old age, and the patient will come to complain of sore throat and halitosis. Why halitosis or bad odor of the mouth? Because there will be retained food particles within the pouch, and this definitely will make a bad odor. And if these contents will be have regurgitation into the mouth, I will find that there will be food that will come out into the mouth or regurgitation, and characteristically this food is undigested food, unlike the reflux that will come from the stomach with the sour taste of the acid. If these food contents that has been regurgitated will go into the respiratory tract, I will have bouts of coughing and choking, and if it will go down into the lung abscess may develop. Also, with time, the swelling will increase in size till it will appear in the neck. At this moment, the patient will have swelling in the neck, mainly in the lateral side of the neck, and with pressure on this swelling, there will be gurgling sound and regurgitation of the content into the mouth. If this swelling is large enough to compress the esophagus, I may have dysphagia, and with lung dysphagia, the patient may be malnourished and he may lose some of the weight. If we go to the examination of the patient, we will find that in many of the patients we may not find physical signs to show. the main diagnosis will be related to the history. However, if I will have a swelling that is large enough to present as a swelling on the lateral side of the neck, at this moment I will go with the same features of examination of the swelling. The swelling will be in the upper part of the neck, related or underneath the sternomastoid, and some characteristics or clinical characteristics of this swelling. The swelling is indentable because we have here contents inside. If I will press, there will be indentation within the swelling. If I will press more, some of these contents will go back into the mouth, so there will be regurgitation of the contents. One of the pathognomonic features that this will not regain its size, except the patient will eat again. Whenever the patient will eat, the swelling will enlarge again. And these are the main pathognomonic features of this swelling. Definitely, generally, I may find some of the chest signs due to the aspiration that may occur with the regurgitation of the fluids. Another swelling that we will discuss is something will appear in the lower part of the sternomastoid, and it is called a sternomastoid tumor. And this one of the misnamed diagnosis within the surgery, because it is not an actual tumor, like it is not something neoplastic. However, the tumor here is indicating a swelling. So there will be swelling in the lower part of the sternomastoid that will affect the shape of the neck and something called the rhineck. Why this occur? Why this swelling occur? It occurs mainly in the neonates due to birth trauma and rupture of one of the vessels that will supply the lower part of the sternomastoid. So there will be ischemia of the lower part of the sternomastoid, and at the end there will be ischemic contracture of this segment of the lower part of the sternomastoid. So with this ischemia, there will be some edema around it, and this infarcted area of the muscle will present as a swelling or lump. Later on, the lump will disappear, and the part of the muscle that has been infarcted, it will be abnormal segment within the muscle with fibrosis. The main complaint will be by the mothers that they will notice in the first few weeks of life a lump or a swelling in the lower part of the neck. Some of the mothers are complaining that the head of or the neck of their babies are just tilted to one side or directed to one side to make it torticollis. If they will try to turn it back, it may cause some pain or distress. And later on, whenever the muscle will have a permanent fibrosis, the swelling will disappear, and there will be special disfigurement with tilting of the head to one side, or what's called torticollis, or what's called the rhineck. This is how the baby will present in the first few weeks, with a lump in the lower part of the sternomastoid muscle. What will be the manifestations? Mainly the swelling will be in the lower part. It will be within the structure of the sternomastoid muscle. The shape will be oblong. It will take fusiform shape, and the anterior and posterior borders are very easy to feel. However, the upper and lower borders, as long as they are within the muscle, you cannot distinguish them in a good way. The surface will be smooth, and the consistency of the lump will be solid. This will be the main presentation of the baby at this situation. However, whenever as you see here, whenever the swelling will disappear and a part of the muscle will be fibrotic like this, I will find that the neck will have a special appearance which is called rhineck. Whenever I have the right sternomastoid here, for example, will be contracted, I will find that the head will be tilted towards the right side. However, the face will be turned toward the left side. Sometimes even it will interfere with the growth of the facial muscles and facial bones and the skull bones, and may have the both eyes will not be on the same level. I will have the eyes on different levels, and the whole picture will be called what's called dry neck. Definitely the treatment will be simple enough by some of the physiotherapy. If it will not respond, we may have tenotomy here, or excision or incision of the fibrotic tendon of the sternomastoid muscle. The next swelling, we are going down into the neck, into the lower part of the neck, something called cystic hygroma. And it is a congenital collection of lymphatic sacs. Why this will occur? The most accepted theory that during the development of the lymphatic system, at the junction of the collection of the lymphatics in the axilla, in the neck, and in the groin, part of the lymphatic channels will not be able to connect into the general lymphatic pathway. So the lymph inside these parts will be trapped in it to make a cyst, and this is called cystic hygroma. The main presentation will be in the areas where the lymphatics will be connected to the general lymphatic circulation in the root of the neck, in the axilla, in the groin, and there will be swelling. We are talking here about the neck in the posterior triangle, in the root of the neck, or in the posterior triangle of the neck. The main presentation of the patient or symptoms that it may be early in life, it may be also large in size to the extent that sometimes it may obstruct the labor, and the normal labor cannot be continued, and the patient will go into cesarean as well. What is the main symptoms? That the mother will notice a lump in the neck. The main concern will be disfigurement because it is painless, but if it will attain large sizes, sometimes it will dissect deep in the muscle, sometimes it will go into the chest, and it may compress the chest to make some of the respiratory difficulty. And these are the main presentation or symptoms of the patients. If I will examine the patients or the baby, the main presentation will be a neonate. In the very early life, the baby will be born with this swelling, so the presentation will be very early. The swelling will be in the root of the neck, in the occipital triangle. The swelling will be globular in shape. It will be soft in consistency, cystic in consistency. Some of the lobulations will be also found inside. It will have the surface that show this lobulation. One of the characteristic features of this swelling is the clear fluid inside. So if I will do a transillumination test, it will have positive transillumination. All the swelling will be translucent, and this is the most characteristic feature whenever we examine this swelling. Definitely treatment will be mainly surgery. Some of the other trials of treatment, like injection of sclerotherapy or having some other radiation to it, but remains the main definitive treatment will be surgery to these cases. The last swelling that we will discuss in the lateral side of the neck is something called cervical rib, and from its name, definitely it is one of the anomalies that may be present, because all the ribs should come from the thoracic vertebra, but if we will find an extra rib that will come from the cervical vertebra, it will compress on the structures that are passing here, which is the brachial plexus, which is the main vessels, arteries and veins of the upper limb. So it will present, or the patient will present, with some of the neurological and vascular symptoms in the upper arm or on the upper limb as well. However, examination of the neck itself may not appear to have some of the abnormalities, because in most of the cases the cervical rib cannot be palpated. Just to have a look again about the differential diagnosis of the lateral neck swellings that we passed through them all, and we go now to the swellings in the midline of the neck. Swellings of the midline of the neck, again, what are the structures that we have? We will go anatomically from above downwards. Just in the submental triangle that we described, we may have something called sublingual dermoid. The ranula may come again. With the relation to the hyoid bone, we have something may called subhyoid bursitis. Thyroglossal cyst, we will go through it in details. And if you go down to the thyroid gland, cervical lymphadenopathy again, and superficial skin and subcutaneous swellings that we will just enumerate at the end. The first swelling in the midline that we will discuss is something called sublingual dermoid cyst, and from its name, it is one of the dermoid cysts that are developed within the body. It is one of the inclusion dermoid, and it is present in the sublingual area. If we look at this picture, don't rush to say what is this monster, because all of us have the same faces while we were having our faces to be developed while we are in the intrauterine life. We will not go through development of the face in details, but just to say that we have some of the processes, something called frontonasal process, two maxillary processes, and two mandibular processes. Just to say at the end that these mandibular processes from right and left will fuse in the midline. If I will have during this fusion some of the inclusion of the ectoderm inside, there will be a cyst that will be formed inside from ectoderm, and it is called dermoid cyst. And this is why it is called inclusion dermoid. Where it will be its place, it will be in the submental or sublingual position within the body. Although, again, it is something related to the congenital development, however, it will present later in life, starting from the 10 years of age up to 25 years of age. The main presentation or the main swelling of the patient, some symptoms of the patient will be swelling under the tongue or under the mandible, under the chin. Otherwise, there will be no symptoms at all, except this will be infected at this moment. It will be painful and tense. We have two types of dermoid cysts. One of them will be superior to the mylohyoid muscle, what's called supramylohyoid dermoid cyst. So by default, you should think that its main presentation will be from the floor of the mouth. Or another one which is inferior to the mylohyoid, which is called inframylohyoid dermoid cyst. So its main presentation will be in the neck as a swelling in the neck. If we translate this to the clinical presentation of the patient, what we will find? We will find that the patient is not newborn. The patient will be an adult patient. The swelling will be in the submental triangle, as you see. It will be smooth smooth in surface. We have well-defined borders. It is not tender and painful, except it will be infected. The edges are clearly defined, and the consistency will be a little bit soft. Sometimes we can feel it bimanually or digitally from inside the mouth and from the other. And as long as it is from ectoderm, the content of the swelling is desquamation of the ectoderm, as we have already said, like exactly in the branchial cyst. It will not have a positive transillumination. The transillumination will be negative in it. Just a few words about swelling that may present within the midline. We have here a bursa just underneath the hyoid bone. So if this bursa will be inflamed, we will have bursitis, and it's called subhyoid bursitis. How we will diagnose it? It is we will find oblong shape swelling, which is related to the hyoid bone. Its transverse axis is the long axis, or the long axis will lie transversely within the neck. And it has, as long as it is bursa, the fluid inside will be clear. It has positive transillumination, and it moves up with deglutition as long as it is attached to the hyoid bone. One other very important differential diagnosis of the midline neck swellings is the thyroglossal cyst. Here is the pharyngeal arches again, or branchial arches again. Here within the endoderm from inside, there will be development of the tongue by two lateral swellings and one medial, which is called tuberculum impar, and this will form the anterior 2/3 of the tongue. However, the posterior 1/3 of the tongue will come from the second arch. So the junction between this and that will make a sulcus here that will appear in the next slide, and the junction is called the foramen cecum. Here is how the tongue will develop later on, and the foramen cecum, which will appear in the between the medial 2/3 and one posterior 1/3 of the tongue. Here is again, and from here there will be thyroid outpouching or diverticulum that will develop, and by time it will descend in the neck to be within the normal position of the neck, opposite to the tracheal rings. It will enlarge in size, and we will have from the ultimobranchial bodies two other parts of the thyroid gland that will have the parafollicular cells that will fuse within the gland later on. The next step is obliteration of this stalk. This is called the thyroglossal duct that will obliterate and will disappear later on. What will, if this duct will not disappear, or one part of this duct will be present, it will form here an anomaly, and it's called thyroglossal cyst. This is the normal path of the thyroid gland till it will reach its normal anatomical position that you have within the previous lecture. And this track is passing from the foramen cecum, and it is intimately related to the hyoid bone. Sometimes it passes through the body of the hyoid bone. Then the duct will pass downwards in the midline of the neck. The fate of this is to obliterate. However, if part of the gland of the thyroglossal duct will persist, it will enlarge to make what's called thyroglossal cyst. So definitely it will be in the midline, it will be related to the hyoid bone, and it will be connected to the hyoid bone and connected to the foramen cecum later on. Definitely this will have its clinical application in diagnosing this swelling clinically. How the patient will present, again, the same as we said in a lot of congenital anomalies that we have already encountered, that the main presentation will be not at the time of birth, but it will appear later on in life, maybe about 15, even 30 years of age. Women here are affected more than men, and the main symptoms will be painless lump in the front of the neck. If it will become infected, it will increase in size, it will present with pain, it will be tender on examination if it is infected. It may present with some other complication, as we said, like infection. Maybe we have here, it may harbor some of the ectopic thyroid tissue in the cyst, so it may enlarge to have some of manifestations of the goiter. And also, this is something essential whenever we treat it, because sometimes this will be the only thyroid tissue that are present. So if we will excise the thyroglossal cyst, we will excise all the thyroid tissue and the patient will have hypothyroidism. Very rarely to have carcinoma within the duct is something very rare to encounter, while it can be suspected if I will have very rapid growing of the swelling more than the usual rate of growth. How the patient will present. I will find here a young boy, and there will be swelling in the midline of the neck. The swelling is globular in shape. You may feel even a track proximal to it, and it is related to the hyoid bone. It is not tender, except it will be infected. The borders are well defined, the surface is smooth, and one of the very important pathognomonic features that it moves up with deglutition as it is attached to the hyoid bone, and it moves up with protrusion of the tongue as it is attached to the foramen cecum, as you all know. How the patient will be treated? The only treatment will be excision of this, but just to make sure that it is not the only thyroid tissue that is present. The thyroid is normally placed in its position, and whenever we remove the cyst, we may be obliged or to remove part of the hyoid bone as well, because the tract or the thyroglossal duct is pulsing through the hyoid bone, and we will follow it to the floor of the mouth till the foramen cecum to remove the whole tract. Other manifestation, if this swelling will rupture due to the infection, it will end by fistula like this. Or sometimes the baby will be born with the fistula from the start. What is this fistula? It is thyroglossal fistula. So I will have with this sinus or fistula a tract that will go up. It will pass also through the hyoid bone. It will pass till the foramen cecum. And if the boy will, or the child will be asked to protrude the tongue, you will find that it have some of the crescent shape edge of the skin, or as if it is moved up by protrusion of the tongue, exactly as we find within the thyroglossal cyst. The last one is the thyroid gland. We will not go through it in details because it has its own separate lectures and it has its own separate clinical sessions, but just to say that it is within the anatomical position of the thyroid. I will have a butterfly shaped swelling if they are uniformly enlarged, and the patient will have very pathognomonic features whenever I will ask the patient to swallow or to give him a sip of water to swallow. The swelling will move up with deglutition. It will move up with deglutition because it is enclosed within the pretracheal fascia. The pretracheal fascia here is attached up to the hyoid bone. Whenever the patient has a swallowing, the hyoid bone will come up with the larynx, and the thyroid will move up with the deglutition. This is really a real example of a butterfly swelling that is present in the front of the neck. Whenever the patient is asked to swallow, like you see here, the swelling moves up with deglutition, which is very pathognomonic to the thyroid enlargement. Either in the midline of the neck or the lateral side of the neck, we may encounter to have a lot of lymph nodes that are enlarged. We will not go through details of that because you have details about this whenever you have it in the last year. However, one of the main pathognomonic features of this swelling that it will be multiple. Whenever I have multiple swellings like this, the first differential diagnosis to come in my mind are the lymph nodes, And definitely it will be through the known sites of lymph nodes, either superficial or deep, either circular or longitudinal. And I should examine the lymph node one by one and to have the criteria for the swelling to distinguish which type of pathology affecting these lymph nodes. The last differential diagnosis that we may have is some of the swellings that may be present elsewhere in the body, within the skin or the subcutaneous tissue, like the sebaceous cysts, like lipomas, abscess, may present in the midline or in the neck, or you may put it in any differential diagnosis. So, because the skin and subcutaneous tissue is one of the anatomical structures that are present in this particular area, so don't forget to include them within the differential diagnosis or think about them, because sometimes the swelling at the end will be just an abscess within the skin. At the end, I wish that you have get benefit of this lecture. Thank you, and meet you in the next lecture, inshallah.